Thanks to the chairpersons and Dr. Calvin for inviting me in for this meeting. And here we're talking about post-MI antiplatelet optimizing beta blocker therapy. I mean, the context of the topic is extremely important because all of us managing patients in the ICU would be dealing with them. All patients treated for ACS should be discharged on DAP, beta blockers, ACE, ARBs, statins, MRA, or SGLT, LPD-1. This is the classical teaching. But times have changed the management of ACS from watchful expectancy in the 80s to primary angioplasty with a low to balloon time of less than 90, which is what is recommended now. So have the evidence in the use of these drugs. So these are 2025 ACC guidelines for ACS. And the layout of the talk would be antiplatelets. We're talking about aspirin, P2Y12 inhibitors, written by IV antiplatelets, long term, whether what happens to patients with high bleeding risk, de-escalation, and in those requiring anticoagulation. So this is the platelet receptor and site of action. First is aspirin, which we all use, the thromboxane A2 inhibitor, which is the cornerstone in the treatment of antiplatelet, and it acts in the conversion of arachidonic acid to thromboxane A2. That's aspirin. And this is the P2Y12 inhibitor. And you've got a whole lot of antiplatelets now with the newer P2Y12 inhibitors, starting with clopidogrel, prasugrel, ticagrelor, and cangrelor. And finally, it's glycoprotein 2B3 inhibitors, which is the final pathway. So aspirin and ACS, there's no confusion. It's class 1 level of evidence A. Thromboxane A2 inhibitors, it reduces vascular death after MI, reduces MI and stroke. In secondary prevention, 160 to 325 milligram is the loading dose, and 75 to 100 milligram is a daily maintenance. Higher dose is associated with increased bleeding with no added risk. And the dose has to be less than 100 milligram per day, especially if the patient is on ticagrelor. So aspirin, there's no confusion. Now comes the P2Y12 inhibitor. It inhibits ADP-dependent activation of platelets, and addition of P2Y12 reduces MACE, but it increases bleeding. So this is what we'll be looking at constantly. It's where the bleeding versus ischemic risk. Clopidogrel, prasugrel, ticagrelor, and cangrelor. Clopidogrel and prasugrel are prodrugs which is metabolized by cytochrome P450. Ticagrelor is a direct-acting, reversible P2Y12 inhibitor. It is CTPT, that's cyclopentyl triacylpyrimidine. And cangrelor is direct-acting IV with restoration of platelet function within 1 hour of drug discontinuation. So this is effective in the acute phase when the patient is being taken for angioplasty, or if you want to bridge. Now, clopidogrel has been shown in the CURE trial. It reduces death, MI, stroke in medically managed patients. And also in the pre-treatment, it reduced MACE in PCA arm. Then came Clarity, TB20, then Comet, which is post-lysis. And this is the only one which has shown evidence in patients post-fibrinolytic. It reduces TBR, death, MI, and TBR, and there's no excess of bleeding as compared to placebo. So post-fibrinolytic clopidogrel is a drug to be used. Now what happened to prasugrel? In the Tricon TB38 is the classical, the main trial of prasugrel. It reduced MACE by 19% at 15 months, reduction in MI, TBR, and stent thrombosis. But there was a 32% increase in non-CABG bleeding, which offsets many other benefits. So, what is the overview? It's more potent than clopidogrel, lesser stent thrombosis, but increased bleeding. Not for less than 60 or more than 75, or with a patient with history of TIA or stroke. These are the contraindications of prasugrel. There's no difference in mortality. It reduces stent thrombosis, but there's no difference in mortality in the Tricon TB38. Not of use in medically managed patients in a cost trial, and no benefit in pre-treatment of ACS. All these trials, prasugrel was given after the angiogram was done, after the anatomy was known. So pre-treatment in ACS, there's no benefit in the ECOS trial. Then came ticagrelor, the Plato trial. There's a 16% reduction in MACE at 12 months as compared to clopidogrel, more than 18,000 patients. There's reduction in death in MI and reduced stent thrombosis among patients undergoing angioplasty. And major bleeding was similar. Now, the meta-analysis, it's the only P2Y12 inhibitor associated with a reduction in all-cause death. But there's a 20 to 30% increase of major bleeding as compared to clopidogrel. Now, this is important because prasugrel, ticagrelor is the only one that reduces all-cause death. The other one, we had reduction in stent thrombosis, but no reduction in mortality while you have the ticagrelor. Now, what happens when you compare prasugrel versus ticagrelor? This is an ISA React file. 4,000 patients. Prasugrel at the time of angioplasty versus pre-treatment with ticagrelor. There's a 26% reduction of MACE at 1 year without any increase in bleeding. Prasugrel had a more potent platelet inhibition and probably better compliance due to less discontinuation of the drug. So in ISA React 5, Prasugrel was shown to be better than ticagrelor. Then had a network meta-analysis which showed there's no difference between Prasugrel and ticagrelor. Of importance, only Prasugrel reduced MI compared to clopidogrel, and only ticagrelor reduced mortality and CV death. Now we have data from the Tuxedo 2, it's the Indian trial which many of us are part of, that is comparing ticagrelor versus Prasugrel in patients with diabetes and multi-vessel coronary artery disease. This is an important trial. It's more than 1,800 patients and 85% had triple vessel disease, 3-vessel disease. The primary endpoint was death MI or stroke or major bleeding, and this happened in 16% on ticagrelor versus 14% on Prasugrel. And there's a numerically higher, non-statistically significant composite of death MI or stroke and major bleeding with ticagrelor. So in this trial, Tuxedo 2, patients with diabetes and multi-vessel disease undergoing angioplasty, ticagrelor was not inferior to Prasugrel, which means Prasugrel was better. So in the ISA React 5 and in the Tuxedo 2, you find that Prasugrel had a probably minor edge over ticagrelor in the acute phase. But again, ticagrelor is the only one that reduces cardiovascular death and total mortality. Now comes to cangrelor, which is a direct acting P2Y12 inhibitor, a rapid and potent inhibition. You got 3 major trials of cangrelor. The first 2, the Champion platform and Champion PCI, were neutral, while in the Champion Phoenix, cangrelor reduced death MI and TBR and stent thrombosis versus clopidogrel in patients undergoing angioplasty. So the recommendation is class 2B for patients with ACS undergoing angioplasty, who have not received a P2Y12 inhibitor. Cangrelor can be given to reduce peri-procedural ischemic events. So it's class 2B, and it's only one trial which has shown the difference. Just a word about glycoprotein 2B3 inhibitors. It was with much fanfare that it was started, but we all know that it's increased bleeding, and many of us have stopped using 2B3 inhibitors. We've got a class 2A recommendation in patients who have a high thrombus burden, no flow or slow flow, and adjunctive use of 2B3 inhibitors can be given to improve procedural success. So it's just 2A, and a routine use of 2B3 inhibitors is class 3. It's harm. You should not be using it. So in ACS, if the patient is taken for angioplasty, whether it's STEMI or non-STEMI, it's aspirin with ticagrelor or Prasugrel. If it's a CABG, it's aspirin again with ticagrelor or clopidogrel. The P2Y12 inhibitor to be started once the patient is stable. If there's no planned invasive evaluation, which means medically managed patient with ACS, it is aspirin with ticagrelor. I think probably in Indian setting, it has to be aspirin with clopidogrel alone. Ticagrelor is much more expensive. You're not planning for intervention, it's because predominantly of finances, and in which case it's aspirin with clopidogrel. And if the patient has got fibrolytic therapy and is not being planned for angioplasty, it's again going to be aspirin with clopidogrel. So this is what you would do in ICU in the patient in ACS setting. But we must understand the time course of bleeding versus ischemic risk. So these are the 2 basic things. Now, in a patient with ACS, the bleeding is very high. The ischemic risks are very high in the first 3 months, after which it plateaus out. While the bleeding risk is high again in the first 3 months, but it remains high. So this is a thing that you have to remember. It is ischemic versus bleeding. The ischemic risk comes down after 3 months, while the bleeding remains as such. So if you're giving dual antiplatelet, we know that there's increased bleeding. So you got great antiplatelets, Prasugrel, ticagrelor. So why not continue with DAPT? The problem is increased bleeding, and that can lead on to mortality. So it's always a balance between ischemic and bleeding risk. So how would it affect the DAPT strategy? You need potent antiplatelets in the initial phase, and this can vary from 1 to 3 months. Beyond this, the ischemic risk is low, while the bleeding risk remains the same. So if you can reduce the potency of antiplatelet after the initial phase, we can maximize the benefit of DAPT and reduce the risk. So this would be personalized care, and this is what we should be aiming to do, rather than just continue Prasugrel or ticagrelor long term. So DFAT reduces thrombotic events, but excessive bleeding is there, and this may necessitate DFAT interruption, which can lead on ischemic events. So the alternative strategies would be aspirin discontinuation with ticagrelor monotherapy, or de-escalation from prasugrel to clopidogrel, or just aspirin monotherapy, particularly in high bleeding breast patients. So this is what we have: is high bleeding breast. You can see almost all the patients we doing angioplasty would fall into one of those criteria. And these are the trials for reduction of DAPT. It's start and stop, DAPT, Smart Choice, Twilight, Global Leaders, Master DAPT, and TICO. Twilight and TICO are the more important trials where you had 3 months of DAPT followed by ticagrelor alone, and you had a 44% reduction in bleeding. This is significant. So this is the guidelines. DAPT on discharge at default would be DAPT for 1 year. That will be the standard strategy. But you have bleeding reduction strategy in patients who have tolerated DAPT transition to ticagrelor monotherapy more than 1 month, class 1A. So de-escalation from aspirin of prasugrel or ticagrelor to clopidogrel after 1 month, which is what I normally do. That's class 2B. And in high bleeding risk patients, you can take off one antiplatelet after a month. You can continue with either aspirin or P2Y12 as per the Master DAPT trial, which is in high bleeding risk patient. You can just continue with one antiplatelet after 1 month of DAPT. On anticoagulation, if the patients are NOAC or VKA for whatever reason, the recommendation is aspirin to be discontinued after 1 to 4 weeks, and it's only oral anticoagulation after 1 year. So summing up, DAPT in post-PCI, prasugrel, or ticagrelor along with aspirin in hospital, especially for angioplasty, continue for 12 months if it's high ischemic and low bleeding risk. Remember, it's only for the patient with low bleeding risk. Strategies to reduce bleeding would be de-escalate to clopidogrel after 1 month, ticagrelor monotherapy after 3 months of DAPT, or single antiplatelets after 1 month in high bleeding risk, and stop aspirin after 1 to 4 weeks if the patient is on anticoagulation. So this much about DAPT. Now beta blockers. This is a game changer because previously we thought that beta blockers should be on all patients with post-MI. It is the standard of care. Reduces MI, arrhythmia, and heart failure, and should be given early and continued long term. But these are recommendations based on older trials, from BART trial in 82 to norbitin timolol, ISIS-1. But what was there in these older trials? The early trials were in the pre-reperfusion era, larger infarction, LV dysfunction, higher sympathetic activation, and beta blockers reduce ventricular arrhythmia, sudden death, and reduce infarct size. What is the difference now? The current treatment is early reperfusion, dual antiplatelets, high statins, AC inhibitors with smaller infarct, preserved LV function, and low arrhythmic deaths. So what is the efficacy of beta blocker in this group of patients? Now, subset of beta blockers are definitely beneficial of patients with LV dysfunction. Anyone with LV dysfunction should be on beta blockers long term. There's no question about it. And this is based on merit. HF, Civis-2, Copernicus, US Carpilor, and Capricorn. And the only 3 beta blockers recommended are bisoprolol, metoprolol, succinate, and carvedilol. These are the only 3 beta blockers recommended for LV dysfunction, and they should be continued long term. But what about MI with preserved LV function? That's a different thing altogether. Now, you got a number of trials coming up. The first one is the reduced AMI, which came in 2024. Among patients with acute MI who underwent early angiography and had a preserved ejection fraction more than 50%, there was no benefit with beta blocker. Came a reboot NIC, which came in August 2025. Again, patients are invasive care after MI with ejection fraction above 40. There was no benefit with beta blocker. The same issue of NEJM came the other one with vitamin DAN block, which showed that among patients with MI and ejection fraction of at least 40%, beta blocker therapy led to a lower risk of MACE than no beta blocker therapy. So you got 2 trials showing no benefit with beta blocker and 1 showing there's a benefit. Why the difference? Now, reduced AMI and reboot showed no benefit, while vitamin DAN block showed benefit. There's a recurrent MI was reduced in the vitamin DAN block, and vitamin enrolled patients with menoca, that revascularization rate was lower in them, and beta blocker may confer some incremental benefit in patients with unrevascularized or non-obstructive CAD, where the effects on heart rate and blood pressure may target the underlying pathophysiology. This probably is the reason why there's a difference in the two trials. And again, this was shown in the guidelines. The ACCHA 2025 guidelines is class 1A, beta blockers to be continued long term. While the EAC 2023 guidelines, beta blockers are recommended in patients with ejection fraction less than 40, class 1A. But for all patients, if the ejection fraction is good, then it's 2A. So it's not one for all patients. Ejection fraction less, yes, you should be on beta blocker. Reserved ejection fraction, it has to be individualized. Now, you've got a meta-analysis of all the recent beta blocker trials, including the individual patient data, and that's more than 17,000 patients. A reboot, reduced MI, beta-metan block, and a capital RCT from Japan. 50% were on beta blocker versus no beta blocker, and the conclusion is that beta blocker did not reduce the incidence of death from any cause, MI or heart failure, with preserved ejection fraction when you have no other indication for beta blocker. That's either uncontrolled hypertension, AF, or heart failure. Among 1885 patients with the same trials, with mildly reduced ejection fraction between 40 to 49, beta blocker was associated with reduction in the composite of death MI. So, with the ejection fraction is less, beta blocker can be given, but ejection fraction more than 50%, there's no benefit for beta blocker. And this is the new paradigm for beta blocker post-MI. LV ejection fraction less than 40, it should be on either metoprolol, bisoprolol, or carvedilol. 40 to 49, you have some benefit, especially if you have associated hypertension, atrial fibrillation, or heart failure. More than 50, if you have none of these, beta blockers have no benefit. So, in conclusion, routine use of beta blockers after MI should not be a uniform approach for all. Guided by ejection fraction and coexisting diseases, this is not a one-size-fits-all. Clinical judgment and personal care is the way forward. Thank you.
It will be probably like, talking to the three papers which you put on from the DGA. So what if the patient has been actually on beta blocker and they develop this sudden onset cardiac failure, reserved ejection fraction, and also like it takes a while for them to recover from the crisis. What we do in such situation, do we draw the beta blocker fully or continue with it, or is there any other way out?
Because you don't have any drugs which reduces mortality in heart failure with preserved ejection. The only one that you have is MRA, that's spironolactone, aldactone, or fenebron now, or SGLT inhibitors. Now, if the beta blockers are given before, for whatever reason, it is for hypertension, hypertension, whatever, it should be continued. But there should be some reason why the beta blocker was given before. If it depends on
during the acute phase. I mean, during acute phase or a refractory situation where it's taking a while, but still the ejection fraction is well preserved.
If ejection fraction is well preserved, if it's heart failure with preserved ejection fraction, beta blockers have no role. In fact, it's probably contraindicated because in heart failure with preserved ejection fraction, heart rate is important. If you have a higher heart rate, it helps the heart. So if it's predominantly heart failure with preserved ejection fraction, beta blockers are not to be given. But if the beta blockers are there for whatever reasons before, I think probably can continue.
Got it, Doctor. Dr. Cecil?
I have one question regarding ticagrelor. Is there any, what is the time interval between classical ticagrelor taking and surgery?
Surgery is prasugrel 7 days, ticagrelor 3 to 5 days, clopidogrel 5 days. Ticagrelor is the shortest one because it's reversible, while the other two are irreversible. So for any surgery, I mean for CMAQ for example, if you want to stop the P2Y12 inhibitor, prasugrel 7 days, clopidogrel 5 days, ticagrelor 3 to 5 days.
3 to 5 days.
The least of the lot.
One practical question, though not relevant to this topic. Patient, because of the prevention of pregnancy-induced bleeding, already the patient is on aspirin, 75 milligram. For emergency obstetric indication, they have to do a cesarean section. There was a profuse bleeding, and the obstetrician has taken all steps to contract the uterus or other maneuvers, and the bleeding continues. How often the aspirin is blamed, or there are other factors in bleeding in this situation?
It's most likely other factors. Aspirin 75 milligram does not cause that kind of bleeding because the patient can be taken for or even bypass surgery on dual antiplatelet along with aspirin and fluid.
150 milligram milligram.
There's no difference. It's only the difference of the GI plating. There's no difference in the antiplatelet inhibition.
So
The 75 milligram is enough.
you wish to say the bleeding is due to some other cause.
Some of the cause. 75 will not cause that kind of bleeding.
What to do? What is any therapeutic guidelines in this situation?
It's essentially a gynec problem. So, 75 milligram is not cardiac protection because that age group does not have a cardiac issue. So it just, you can do what? Stop aspirin, give whatever drug you want.
So look for the other cause
Yes.
and other methods to control the bleeding.
Sir, I have a question, sir. Sir, following a PTCA, how long these dual antiplatelets, statins, and beta blockers has to be taken? That's the user question patients are asking your GP. For how long? Is 1 year or we used to say lifelong?
Now, dual antiplatelet is only for 1 year. After 1 year, it will be only single antiplatelets. Whether aspirin or clopidogrel, you've got more evidence for clopidogrel. So after 1 year, the patient should be only on one antiplatelets, preferably clopidogrel. And statin is lifelong. Beta blocker, if the LV function, depends on the LV function. If the LV function is good, beta blockers need not be given. And even if you are giving beta blocker for whatever reason, if the ejection fraction is low, you have to continue. If the ejection fraction is good, after 2 years, there's no benefit of beta blocker side effects.